Okay, it's precisely 5 o'clock in the afternoon or evening. Um, Good evening, everyone. It's a pleasure having you again to our virtual grand rounds in radiation oncology. You know our format. I will give you a very quick introduction. As always, we aim to present you the latest science presented by top speakers in a very interactive format. You know that we try to do it every month on the first Wednesday, but we have to adjust them based on the availability and overlap with different meetings and other assignments. So today we're on Tuesday, obviously, and this is a reminder that I'm very grateful to the endorsement of our societies, the ASTRO, SASRO, and the DEGRO Society. So many thanks again. And also a reminder, all webinars have been recorded. So if you missed any of the fantastic speakers before, the important clinical trials which have been highlighted, just go to our homepage and you will find the recording of every one of them being there. Today we have a slightly different schedule, and I'm very happy about that because we have just been a few weeks coming back home from the ASTRO meeting in San Francisco, which was packed with science, which was for some clinical trials changing or at least informing our practice. There was lots of science in the field of prostate cancer about whole pelvic radiation, the fractionation SBRT versus hyperfractionation, also combining SBRT with, call it novel, systemic therapies, lutetium, and also beyond prostate cancer, there was evidence for osteoarthritis, proton radiotherapy, and for bladder cancer. It's a pleasure that Professor Balermpas was at the meeting, has been invested quite a lot to collect these most informative clinical trials, at least from our perspective, and will present you an overview. And I would like to ask you, everyone being among us, please ask questions. Use the questioning and answering functionality to make that interactive, to make the learning experience the best. With that, I would like to hand over to Panos. The floor is yours. Looking forward to the first 3 papers and clinical trials. Then we will do some discussion, and then we will continue for the last 3 ones. Panos, please.
Dear colleagues, I greet you everybody. Thank you very much for joining late in the afternoon. Let me share my screen. It's good visible? I think yes.
Yes, it is. Perfect.
Perfect. So, as Matthias already said, there was a lot of important science in this ASTRO Congress. One of the fields with the most data presented was prostate cancer. And I apologize in advance if I don't include every trial. Of course, it's impossible. And such talks like today have always some subjective character. But at least from our point of view, I will present you the ones that have more potential to be somehow practice changing. So the first trial, the NRG RTOG, is about whole pelvic radiotherapy. It is needed, it's not needed in intermediate and favorable high-risk prostate cancer. Then some data about comparison of SBRT with a classical IMRT for intermediate risk prostate cancer. Then an oligometastatic trial with combination of lutetium and ablative stereotactic treatment. And then we will proceed with the potpourri from other regions and localizations like osteoarthritis, oropharyngeal carcinoma, protons versus photons, and adjuvant post-cystectomy treatment in bladder cancer. Let's start with the androgen deprivation therapy and high-dose definitive radiotherapy plus minus whole pelvic radiotherapy. This was presented by Professor Macroads, and this trial had the goal to assess whether the prophylactic whole pelvic radiotherapy improves overall survival. Obviously, it had to be a very large trial, and it included, as you see, almost 2,500 patients to be to have the power to demonstrate the difference in overall survival. The selection of the stages was a bit arbitrary because it was done before the current risk categorization. So it included both unfavorable intermediate risk and favorable high risk. with a macro's lymph node involvement risk of at least 15%. However, the PSA had to be below 50, and it included only T1 to 2B tumors, no T3 included here, very important. So the intervention was quite simple, standard radiotherapy dose, normofractionated up to 79 gray O with a brachytherapy boost was also allowed, and the androgen deprivation treatment. And this was randomized to receive prostate only versus whole pelvic up to lumbar spine 4 to 5. As you see here, no difference at any time point regarding overall survival. These curves will never separate. So regarding survival, after 12 years, there was no difference. The median follow-up is about 9. So the 10-year overall survival of 68% is excellent, of course, for both arms, and without the trial is negative. Interestingly, there were even less deaths attributed to prostate cancer as the investigators originally thought. So it was even more difficult to see any difference. But there was indeed some difference in 10-year biochemical failure. It was more common as expected in the prostate-only radiotherapy. It was significant due to the large probe of patients, of course, but in absolute numbers, still rare. However, it is some kind of practice changing because whole pelvic radiotherapy is still practiced in many centers worldwide. And we think that after this trial, probably at least less patients are going to receive it, or at least we have more data to inform our patients. There was interestingly a trend for improved survival in the patient cohorts with longer follow-up and higher risk, but this is not surprising, of course, and this never is until now significant. So this is an important trial. This has, for the first time, enough power to solve this unanswered question, whole pelvic, yes or no. There were high survival rates and low morbidity for prostate only and for whole pelvic radiotherapy. There were no unexpected or high risk toxicities in the whole pelvic treatment, importantly, and not directly comparable with the well-known Poverty trial. The Poverty trial, I want to remind you, included mostly T3 tumors, even T4, and the median PSA with 28 was much, much higher than in this trial. The majority had even a risk for over 35% according to the Macroach formula, and in this trial, the baseline was 15%. So there is no benefit for pelvic radiation in unfavorable, intermediate, and favorable high-risk prostate cancer patients, at least not with this profile, and at least not regarding overall survival. Let's proceed to the second prostate trial. It compared in phase 3 setting ASBRT versus hypofractionated IMRT. It was presented by Rodney Ellis from South Florida and Tampa University, and it was a superiority trial. The goal was to demonstrate superiority for a composite endpoint, disease-free survival, and health-related quality of life, which was based on both bowel and bladder function. It was randomized with a number of patients included about 690, and it allowed intermediate risk Gleason 3+4, with PSA below 20, or Gleason 6 when PSA was 10 to 20. So favorable intermediate or low risk patients. So the intervention was a standard IMRT in 28 fractions, or according to the CHIP protocol, 60 gray in 20 fractions, also considered standard nowadays, with standard margins of 8 millimeters and 5 millimeters to the rectum, compared to ASBRT, 36.25 in 5 fractions, with somehow reduced margins, but as they're commonly used for most centers applying ASBRT. And as you see here, interestingly, the disease-free survival was negative for ASBRT. There was even a difference in favor of normofractionated or slightly hypofractionated treatment, at least a numerical difference. But the bowel outcome was better with SBRT, significantly better, which is not surprising as they used, like said before, smaller margins. There was no significant difference in the urinary outcome. So this study is not directly practice changing. Why? Because the study was negative for disease-free survival. We have seen that both techniques yield excellent results, but the SBRT resulted in significantly higher biochemical failure rates. As you see here, this reached significance, the BPFS at 3 years, although there was no difference in primary urinary quality of life and improved EPIC bowel quality of life as well for the secondary endpoint, sexual domain and urinary incontinence. So SBRT is indeed promising, at least related with lower toxicity, but it clearly demonstrates the need for dose escalation in prostate SBRT. So it's an important trial, although negative, because it demonstrates, of course, the excellent results of modern radiotherapy and SBRT for prostate cancer. It demonstrates for the first time that rectal spacer is associated with improved bowel outcomes because it was a predefined endpoint and stratified also rectal spacer, yes or no, in both arms. But most importantly, it shows that the lower dose compared to other standard trials in this setting, like the PACE-B, resulted to lower BPFS. And that is probably the main reason why the results were slightly inferior to the moderately hypofractionated regime. So SBRT is standard of care. It's associated with low toxicity, but the dose escalation is needed. The third prostate trial was in the oligometastatic setting, presented by Amar Kishan from UCLA, and for the first time had the innovative concept of combining lutetium PSMA neoadjuvant treatment to metastasis-directed ablative radiotherapy and investigate if it results in an increase of PFS, where PFS was defined with new PSMA-avid lesions or initiation of salvage treatment or death. It was randomized 1-to-1, phase 2 trial, though, with 92 patients, and 1 to 5 lesions classically were allowed. Either SBRT to all lesions versus only 2 cycles of lutetium followed by SBRT. As you see here, the primary endpoint is highly positive, and it almost doubled the median PFS. The most events correlated to new lesions detected, and there was only very rarely an in-field progression. It's not yet practice changing because it's phase 2, a small trial, but it's positive with very promising results. The addition more than doubled PFS, and very important for our patients, the androgen deprivation treatment-free survival increased significantly up to 2 years from treatment. The only grade 3 event observed was lymphopenia with 7 versus 5%. No other grade toxicity observed. And this study was extremely good designed regarding the translational program. They evaluated T-cell receptor rearrangements. They evaluate predictive models based on single nucleotide polymorphism, and they identified for the first time in this setting biomarkers that seem to work. So it's an important trial demonstrating the efficacy of lutetium PSMA in OMD. It shows that combined treatment can further defer an androgen deprivation treatment and identifies for the first time biomarkers for this setting. The combination seems to work and can defer progression and ADT. A phase 3, of course, should follow. Then
Panos,
maybe
may
we
I
can
propose
stop. Yes.
maybe we stop here and allow for some questions. I don't see any in the chat, but please use the Q&A functionality to ask questions. These are important clinical trials, and you might have some questions on the details, as has been shown on the annual meeting. Maybe let's get started with the LUNAR trial you presented as last. It is a quite challenging situation in my clinical experience. You have a patient had prostatectomy 5 years ago, now has become a bit elderly, has a single bone metastasis. Do you treat locally? Well, we are radiation oncologists. We tend to say yes, but what is the optimal systemic therapy? You could say, you quote Pete Austin, say, well, just do SBRT to defer ADT. We could say use the Radiosa trial, 6 months ADT. We could use extend and say intermittent ADT. We could say, well, these are metastatic cancer patients, so they need the full systemic therapy as in any metastatic case. So any answer to this question, how do you consent your patients if you have them? Do you try to kind of explain them the consequences of the different systemic therapies?
Of course, one should consider also the side effects. ADT has well-known side effects. That's the reason why many of our patients are very negative bias against ADT. Lutetium is not without side effects. However, this regime with only 2 cycles is probably associated also with less chronic toxicity as we are used to. Many people have concerns about the xerostomia and xerophthalmia, and this rarely reaches grade 3, as we know from head and neck cancer. Grade 3 is a dramatic situation. But of course, there will be patients with grade 1 to 2, xerostomia and xerophthalmia. I guess this study didn't show any severe adverse events to this regard, but it's not powered probably. It has not so long follow-up. I guess the important message is that surely the 2 cycles are better tolerable than our well-known palliative lutetium treatment, but the patient should know the possible adverse events. And for me, this 24 months, 2 years without ADT is really appealing.
There's another question in the chat about the whole pelvic irradiation and for comparison with the POP-RT trial. A valid comment is obviously Energy RTOG was a multi-center trial recording 2,500 patients, even if the risk profile has been lower. But how can we compare it to the POP-RT trial, which was effectively a single center trial by Tata Memorial with substantially lower patients? So do we have a strong argument now that we have the energy trial to say, well, in higher risk patients, we should go for whole pelvis? Or is the evidence mostly based on the energy trial, despite the difference in inclusion criteria and patient characteristics?
Yes, I mean, the POP-RT trial is unicentric, but it was a very well-designed trial. For me, the strongest argument is that you cannot compare them. If you see, there was completely different populations. The POP-RT had even a sufficient number of T4 patients, and the energy was up to T2. This is one main difference. The other difference is both PSA was higher, and both the risk, according to the Macrod's formula, was almost double the median risk of this patient. So there are 2 completely different populations, and I think both trials provide valid results. If a patient comes to me with very high PSA, with unfavorable high risk, I would go for whole pelvic problem.
We have a couple of other questions, obviously, for lutetium. If it would become a standard of care in oligometastatic patients, which it is not on this trial, what about the supply chain? The logistical demands are quite high. Also, the costs, which are quite high, despite only being 2 cycles. Any comments on that?
I mean, in the US, of course, they will continue now with a phase 3 trial, and it's easier because you are not allowed to forget in the US the radiation oncologists often apply the radionuclide treatment themselves. So this allows for much easier logistics. It stays in one hand. The costs are very high, but if I think that we are doing anyway a lot of repeat stereotactic ablative treatment and repeat the PSMA exams, this might reduce the number of repeat SBRT.
Okay, looking at the last comment to the hypofractionation versus SBRT trial, you made also from my perspective the most important point. I mean, SBRT is not SBRT. I mean, it depends on the details. What are the margins? What is the toxicity in those? So if we go for SBRT, which is a standard of care according to PACE-B and according to the Bitmark trial from Scandinavia, we need to apply a proper dose. SBRT will have very poor outcome if it would use poor technology and if it would too low doses. That might explain the small difference you have observed. What is, in your feeling, kind of the current fractionation you would recommend for Professor SBRT?
As we have seen, and for time reasons, I didn't show it here, even the principal investigator demonstrated after that an alpha beta calculation and everything. Actually, in 5, you should apply 5 times 8, at least to the dominant lesions. There are different concepts. You can apply to the CTV, to the prostate, this 5 times 8, but this is at least for the macroscopic tumor, the dose needed to control it.
Maybe a last question. You made a comment about the rectal spacer. In my experience, the rectal toxicity is almost absent. So if patients are explaining symptoms after prostate SBRT, it's mostly some urge symptomatic, some polacisuria, maybe some nocturia, but bladder toxicity, bowel toxicity in terms of rectal bleeding, irritation, has become very rare. Is there still a space with very small margins, high precision for rectal spacer? That was not randomized in the trial.
This was predefined and stratified. To be honest, the endpoint was regarding subjective quality of life, mostly based on grade 1 to 2 toxicity. There was no difference in objective high grade toxicity, no bleedings, etc. So it was only for the low grade toxicity, and there it seemed to be significant.
Okay, I don't see any additional questions in the chat, so let's continue with the kind of mixed bag and let's start with osteoarthritis.
This was the first trial, randomized phase 3 worldwide to test the effect of radiation on osteoarthritis. It comes from Korea, from Seoul. We know there were Dutch trials, phase 2, if I'm not wrong, randomized in the past, which didn't show any benefits. So maybe for those of you coming from German-speaking centers, you know, it's practiced decades ago. It was established and one of the most old treatments. But in the rest of the world, it's everything else than standard. And this trial wanted for the first time to demonstrate the efficacy of the low-dose radiation for this indication. Very well-designed trial with established questionnaires regarding response, randomized in 3 arms, even including a complete sham irradiation with 0 gray versus the sham arm from the Dutch trial with 0.3 gray in 6 fractions and the usual German concepts of 3 gray in 6 fractions. Very important in contrast to other trials which are biased by concomitant analgesics. It was not permitted except for rescue drug, and it was restricted during the first 4 months, was controlled with questionnaires, and the patient have to have osteoarthritis of Kellgren-Lawrence grade 2 and 3, so not very high symptoms, and the baseline walking pain also to be included. So very well controlled and designed trial. And you see here, 1 month after, there was no difference between the arms, but still a high response rate, which indicates the strong placebo effect of such treatments. But the primary endpoint after 4 months was clearly positive. You see here, especially the comparison between the standard fractionation and the standard dose to the complete 0 irradiation was enormous and highly positive. Almost 30% after 4 months. And this is only one cause. You know, in the most recommendations, like in the German recommendation, you are allowed to provide a second course if this is not enough, and even a nice difference between the standard arm and the low dose, and the low dose and the zero arm. The study was, of course, not powered to show all of these differences, but you see there is some logic and some validity in these results. So for me, it's clearly practice changing. There were discussions after the Dutch trials if we're doing the patients a good treatment, if we provide them a good service, if we radiate them. But yes, this study with very good sophisticated design showed that RT in low dose can be applied for arthritis, which was no standard in most countries of the world. The response rate is highly significant, and you see the low, very low 0.3 irradiation shows no significant difference to the sham group. There was a clinically meaningful improvement more frequently compared to the other arms, no toxicities at all observed, and interestingly, there were no difference in the secondary endpoints, such as the virtual analog scale or the rescue analgesic use, but the function was, like said before, objectively and subjectively clearly improved. So it's an extremely important trial, the first high-level phase 3 for osteoarthritis, multicentric design, objective endpoints, function-associated endpoints for the first time, and with control analgesic medication. Low-dose radiotherapy is a standard of care for this disease. Let's proceed with the head and neck cancer trial, more specific oropharyngeal carcinoma, the Torpedo trial from CRUK, presented by David Thompson from Christie's NHS. It was aimed to investigate the differences in outcome between IMPT proton modulated treatment and the IMRT for oropharyngeal carcinoma, with the co-primary 1 year after treatment, consisting of both clinician-reported gastrostomy dependence on or important significant weight loss, and a patient-reported University of Washington quality of life. It was powered to test each of them to 2.5% significance level, randomized 2-to-1 to receive protons versus photons, over 200 patients, locally advanced oropharyngeal cancer. As you see, half of the patients had really large tumors, and many of them also very advanced lymph nodes, and there were also smokers allowed. Standard treatment, 70 gray, 2 cycles of cisplatin 100, so like you would apply probably in your clinic. And the clinical co-primary, after 12 months, you see no difference at all in feeding tube use, very low rates, showing that modern radiotherapy for oropharyngeal carcinoma is a very, very well-tolerated treatment, nothing to compare with 30 years ago. Interestingly, the weight loss was significantly higher in the proton arm, and nobody can explain that until now. There were discussions, but no good suggestion for that. And the combined objective endpoint of feeding tube use or G3 weight loss was, of course, not positive for protons. If one can say this, it was even significantly better, at least in terms of weight loss for photons. The same applied to the subjective endpoints. And interestingly, I do not show the data here, but although there was always some significant, small but significant dosimetric difference in the organs at risk in favor of protons. So it is practice changing, in my opinion, because until now in many countries, from the US to Denmark, UK, Netherlands, patients with oropharyngeal cancer were very commonly referred to protons. This will not necessarily be the case in the future, I think, and in some health systems, even it won't be reimbursed anymore. Both treatments are very good, so very low gastrostomy dependence rates. No difference in patient-reported outcomes. Again, an argument not to refer to protons for this indication. Also, the MDADI score, the most used MD Anderson questionnaire for dysphagia, was no difference at all. And of course, no difference in oncological endpoints. I don't show the data, but the curves were completely overlapping. Excellent results with both modalities, about 95% control and survival. So it's very important trial, demonstrates for the first time with such a high level of evidence and such validity this comparison. This was in contrast to the other trial, the MD Anderson trial, with independent national RTQA, multicentric in over 20 centers, fully function sparing optimized RT also in the IMRT arm, protocolized reasons for replanning, always for adaptation. There was the same targets and constraints used on both arms. There was a minimum defined threshold for feeding tube, so it was not arbitrarily decided by patient or caregiver when you get a feeding tube and when you remove the feeding tube. And importantly, in contrast to the MD Anderson trial, there was no single crossover between arms. In the American trial, it was up to 20% crossover. And the American trial only showed that protons are not inferior, which we actually knew. So there is no need for protons in this indication. Last but not least, bladder adjuvant radiotherapy, the BART study from the Tata Memorial from India. This is a disease where, with the clear advances in systemic treatment, one thinks that radiotherapy might not play such important role in the future. However, this trial was had a very important and smart question to investigate the potential of post-cystectomy radiotherapy to reduce locoregional failure. Primary endpoint, the 2-year locoregional failure, and was randomized 1-to-1, and high-risk muscle invasive bladder cancer with all known risk factors was included. This is the most common states, of course, for this disease, was randomized to observation. Observation means surgery and chemotherapy versus 50.4 gray in 28 fractions. So a well-tolerated, usually used regime for pelvic radiation. 90% of the patients in both arms received chemotherapy. It was not prerequisite, but of course, according to the guidelines at the time point the study was designed, and it was highly positive. You see here in the intention to treat population, the large difference of 11% significant, and the per protocol population was even higher. In the per protocol population, only 7% of the patients saw with radiation a locoregional recurrence. So it's surely a positive trial, no doubt about that. It's potentially practice changing. The benefit was clear, but no immunotherapy was used because the study, I said before, was designed before the advent of immunotherapy for this indication. The locoregional control was significantly improved. The benefit was demonstrated in the forest plot for every subgroup, even for nodal positive, where we, of course, intuitively would say this patient would get first distant metastasis or even die at distant metastasis, and very low toxicity. Although small bowel was in the pelvis, of course, to some degree, it was a modern IMRT used with bowel preservation, and no isolated locoregional recurrences was observed in the radiotherapy arm. Most patients receive chemotherapy, which is some kind of standard. This is the largest trial demonstrating with the highest level of evidence the benefit of post-cystectomy radiotherapy. It used modern bowel sparing IMRT, and such observed no high-grade toxicities. And importantly, this is important for tumor conferences, the local failure remains a common problem in advanced bladder cancer. The median overall survival after local failure is only 9 months, and modern post-cystectomy series demonstrates still a local failure of about 30% at 5 years, even the ones using immunotherapy. There were even analysis in the SWOG trials and TOLTC if chemotherapy reduces locoregional failure, although it improves survival, and it was not the case. And there is still no evidence that immunotherapy reduces locoregional failure. So for me, post-cystectomy radiotherapy should at least be discussed in multidisciplinary boards for high-risk patients, make some smart patient selection, even in the immunotherapy area. Of course, studies will follow, including immunotherapy, and consider always if the patient for any reason receives no immunotherapy. So this is the summary. So should we radiate pelvic lymph nodes in intermediate, favorable, high risk prostate cancer? Not actually, with small tumors with lower PSA. Should we apply stereotactic radiotherapy to intermediate risk prostate cancer? Yes, but please only in adequate escalated dose. Is there a place for radionuclides in oligometastatic prostate cancer? Most probably yes, always in combination with ASBRT, but we will see in the future. And for the other diseases, is radiotherapy of osteoarthritis effective? Yes, we finally can say that after decades of use that it is effective. Should we apply protons for oropharyngeal carcinoma? No, there is no benefit for any endpoint clearly. And is there a benefit of post-cystectomy radiotherapy in high-risk bladder cancer? Yes, especially for patients not receiving immunotherapy. Thank you very much.
Thanks, Panos. Again, we have some time for questions. We communicated that we are running slightly longer to allow for sufficient numbers of questions. My first would be about the osteoarthritis. I mean, if I'm running to my tram and my train, I get knee pain, and that knee pain is for a couple of days. I've done sports when I was young, so I'm getting older now. Am I a candidate for osteoarthritis? So how do you select patients? I've not known this Krell-Green-Lawrence score. So can you enlighten us? And if you say it's a standard of care, how do you select patients?
Yes, what I did not refer to the patients had, every one of them should have also radiological imaging, which showed signs of osteoarthritis. So this was a combination of X-ray. Everyone should have some X-ray evidence and have this functional score, which shows the clinical signs. So I'm not orthopedics, but this was a prerequisite to be included.
And are there any kind of needs for additional imaging? You might assume if it is kind of, call it a cold osteoarthritis, where it is just bone against bone, maybe the effect is going to be smaller, but if you have this inflamed osteoarthritis, and then it might work better. So could that be, has that been tested? Has it been discussed to select patients using MR imaging, PET imaging, whatever?
Indeed, this was not discussed. Not discussed. They persisted at the simple X-ray. Like said before, every patient had to have some signs in the X-ray, but no other imaging, which like MRI, which could use so collateral damage. Of course, as we know, some tendons or cartilage can also play a role, and this was not included in this study.
It was a strength from the methodology design that pain medication wasn't allowed. From a practical perspective, you may ask, I mean, you're having osteoarthritis, so why don't you take a pain medication? Just take a pill. So how do you kind of translate that into clinical practice where many patients will have pain medication, which is not something serious as
So I mean, the late function will be improved, I think, and this has to be so in order to avoid bias. But in daily practice, you can communicate to the patient that after 3 to 4 months, he or she could start reduce pain medication, and this would also help to decide if they need a second course of treatment.
You made a quite strong statement on protons for oropharyngeal. You said it's a benefit of having a multi-center trial for sure, but how about the learning curve? I mean, we have learned from SBRT, IMRT, from protons that these are not simple techniques, so it takes a learning curve. So is there still some kind of rationale to say, well, we might not have been at the top of the learning curve for the protons, but maybe for the IMRT, that explaining the lack of a difference?
It could be, though these were experience centers, and like said, so regarding contouring, prescription, etc., it was strongly controlled and clear. Of course, regarding planning, there always is some individual difference between centers, but this was also high-end proton treatment. I want to stress, no all the techniques with scattering, etc. So it's difficult to say that this technique will become much better than it was. And these are patients with good prognosis where we're discussing even de-escalation. So to show a statistical significant difference in an important endpoint, it's very difficult. There always be single patients that might benefit though. Difficult to identify them in clinical practice. The Dutch model is very nice and very good, but it's based on NTCP. So we don't have a real, very good clinical rationale yet.
I see two comments about the learning curves in protons, which is something, of course, to be considered also on the details of radiotherapy planning, on those constraints. So I think it's always important to look at the details, how the respective call it techniques were being practiced and not just using a name. There's
And
another
maybe a
question of
last comment on that, which also persuades me about the quality of the proton treatment was that, like said before, in almost all organs at risk, there was indeed a dosimetric difference in favor of protons, in favor of
an
protons.
an important question to the BART trial in bladder cancer, where immunotherapy is the standard of care. So how do you sequence? I mean, in that trial, immunotherapy was not given. So we have the issue of saying, well, we improve local regional control, which might not be the most valid endpoint for a medical oncologist. We do have an indication for immuno, they have not been combined. So do we need to wait for an adjuvant trial combining radiation and immunotherapy? If you would go into your tumor board and make a case, how would you sequence?
I mean, if I had this cancer, I wouldn't wait for a phase 3 trial, especially because for another with immunotherapy, especially because these recurrences have detrimental effect on quality of life. So I wouldn't have any concerns applying them simultaneously. We have seen both the results recently from Nivo post-op for head and neck cancer, which at least as a sensitive region as the pelvis. We know the pelvic combination of cervical cancer. So I would start with both of them. Start maybe with 1 to 2 cycles of immunotherapy, like we know from the other diseases. Continue with radiotherapy simultaneously, and then proceed with the immunotherapy.
Another important question to the BART trial, were patients with a neobladder being allowed and enrolled?
They were allowed, but there almost no one enrolled. This is a very important, good point. That was the first question that came into my mind. Almost every of these patients had a stoma.
Mhm.
And neobladder is, especially in Europe, a very common
Yeah.
situation. There was, if you have the neobladder, of course, you have less overall bowel in your field, but the neobladder will probably also show some side effects.
Maybe the last question again about the torpedo trial proton. Was there adequate IGRT for the proton arm? Today, I mean, we're using in daily practice for photons, VMAT, CBCT image guidance. Was that being available for proton and maybe also detecting kind of more systematic changes? Was adaptive radiation being allowed in both arms? Has that been recorded?
Yes, adaptive radiation was allowed in both arms, and the treating physicians had to document in both arms the reason and the time point of adaptive radiation. And IGRT, I don't remember, to be honest, the exact prescription, the exact protocol prescription, but it had to be identical in both arms.
And was there a difference in adaptation? Because you might assume if you're having a cone beam CT more frequently, you see the systematic changes, you adapt more frequently.
I don't know
Um,
this data, if it was more
okay, would be
frequent.
interesting to see. Okay,
Yes.
we are at 5:45. Many thanks, Panos, for collecting all the data, for giving us a very precise and comprehensive overview. Many thanks for everyone joining. Many thanks for asking the questions. And we will communicate the next virtual Grand Rounds lecture very soon, where we will focus on one specific trial again and not on an overview. Many thanks for joining and have a lovely evening. Bye, everyone.
Have a nice evening. Bye.